Thank you, we should. Yes, it's 9:05 for a beautiful Monday, and we are initiating our week with this uh, training that gonna bring you together to work on the CQM infrastructure. I want to welcome every single one of you, and those who are coming later, though they will be welcome as well. And someone going to be catching them in letting them into the room. And for the team, please keep an eye on your phones because sometimes they just text. I'm not able to get in. Please help me what to do. So, and let's, on behalf of the AA and the Grant Management, Sonia Hughes, she asked me to mention that she is aware, she is supporting, full support this initiative of developing this training series for CQM programs around Dallas, EMA, and Denison Chairman HSDA. Again, welcome. And what we have today is a little bonus for you as a token of appreciation that you have the training YouTube channel that you were asking. Dwight asked that question about the link, and some other of you ask about this link. This link, it's very easy access to the last two this training and the previous one that you're gonna be able to have access on that YouTube channel. But what is the training series toolkits will be saved on the glass cube that we will working on, and that will be available for you. You have to create your own account on the glass cube, and you'll be able to revisit that toolkits that will help you to initiate or board people who are new into CQM, or you want to be trained even actually deeper into CQM. You'll be able to have that guide as a steps into that. Again, welcome this morning, today, and this session will be recorded as well as the previous one, so you will have access to that. Michael, or Angie, I'm sorry.
Good morning. We just want to go over some helpful hints for the Zoom room, Zoom session. So please enter your name in the chat room when you join. If you need to exit the full screen, press escape. You can hover over the top to change your view options, and we ask you to please mute yourself right away. And if you have a question or a comment or something, you can unmute yourself and then mute yourself again. Please use the chat room for comments and for questions. And as Oscar said, the meeting will be recorded and available afterwards.
May I ask you something? I'll not ask you, but I forgot something so very important. We've been seeing Michael like every week, sometimes 2 or 3 times a week, Jamie and Michael. These are consultant hired help with Jamie Trank. They're going to join us in this presentation. Actually, they are the drivers of this training and the consulting group that is helping us to revamp the whole CQM program in Dallas. Welcome, Michael. Please, thank you so much for that. And I forgot that little piece that I was writing it down and I forgot, but I'm sorry. You're in.
Okay, the next slide ready?
You see it?
I can see it a little bit. This is our group, our crew, and we're gonna show you how to mute, where there's the mute button, where Oscar's pointing to, over in the left bottom corner. And there I am as well, pointing to other buttons that are on the screen. You wanted to stop your video or something else. Just if you need help too, I know we all use in different platforms and you're not sure how to do something, just put a question in the chat box or quickly unmute yourself and someone will be able to answer your question on how to navigate the system. This is Jamie. Jamie's one of our consultants, just happened Michael. And she's giving some pointers as well. I can't see exactly what she's pointing to. My little box is blocked down there. Somebody
it's the chat.
Chat room.
Oh, okay, the chat room. So she's showing you where the chat room is there. And there's Oscar pointing upward to the view option. So you see where that gallery view is. You can click that to have different view options, if just yourself or you want to see everybody like in a Brady Bunch type format, click on that and see what different options you have there. And this is just the crew.
Woohoo! Yay!
Hey, Regina.
Okay, thank you, Angie. So once you join in on the session, myself and the CQM staff will be renaming your tagline on your name. So by adding your agency name, we are, and this is just to allow us to help facilitate and signing you to your appropriate breakout sessions. So if you'd like to add any information, your pronouns, which we do encourage, but just please do not erase your agency name. That helps us divide you up into your breakout groups for later on today. If you get disconnected and rejoin without your agency name, we will try to pay attention and add it back for you. Next slide, please. Okay, so once you've been tagged with your agency name, we can talk about this breakout room. I don't know if some of you are familiar with breakout rooms in the Zoom format, but what's going to happen is each participant will receive an invitation to join the breakout room, and it's going to look like the little box there, and you can click. What you do is to accept that invitation, you go ahead and click join. And then once you will then be moved into your breakout room. Once you're done, your session is done within your breakout room, when your time is up, you'll actually be notified to rejoin the main room. Now here's the catch with that, because what it will do, it'll do a countdown time. And actually, once it counts down, even if you don't click rejoin into the main room, it's going to automatically put you back into the main room anyway. So that's there, I think. And that's it for the Zoom breakout process. And if you have any questions, please do not hesitate to ask either in the chat feature or raise your hand and let us know, and we'll be happy to help you out. Angie, back to you.
Okay. So by the end of today's session, we're hoping that you'll be able to name 2 components of the CQM infrastructure, list the primary components of a comprehensive CQM plan, explain how to use attachments to complement your CQM plans in a way that helps to keep the plans concise and manageable, describe the importance of a variety of stakeholders' involvement in the plan, in the planning, implementation, and evaluation, and complete a review of your CQM plan, and be prepared to discuss 3 possible revisions to it at your next CQM meeting based on today's presentation. Okay, Regina.
Okay, so if you haven't already received the participant toolkit, it will be made available to you. As Oscar mentioned, we're going to put some on the QI actual page, so you will receive these items. So the presentation for this slide, the slides for this presentation, I'm sorry, the CQI Quality Academy module links, the CQM Plan checklist, the organizational assessment components related to CQM infrastructure, and any action planning questions that may arise. That will all be included in the participant toolkit and made available for you later. And Oscar.
Okay, if you didn't receive the toolkit on this email previously, please let us know. We want you to have that toolkit as a guide. And here it is, as a training, we have this question for everyone. I will totally encourage you to please look at it and answer those. The first one is, who takes charge of revising and editing your CQM plan as your subrecipient agency? Well, remember, you develop the plan, you use the plan, but you update the plan. So, different steps. And who is in charge of that at your agency? You do, someone else, you share responsibility with someone else, or definitely you don't have an idea. It's good, it's safe, it's a safe zone. It's a safe fly zone. You say, like, I have no idea. It's good to know. We want to have that feedback from you guys. And how many trainings have you attended in the topic of CQM plans? The first one, not very many, fair amount.
So we have 6, 7, and 15 votes in. I'm sorry,
And
Oscar, what were you going to say?
Yeah, there was a question in the chat room, Oscar. I'm sorry.
Yes, go ahead. Karen was asking if we are including on-site QA training at our agencies. In general, not specifically this. We know the answer for locally, so we want to know your point of view in general, if you have attended training outside or inside.
So let's see the results.
All right. For who revised, edit, and update the CQM plan, you have the kind of even, someone else 27%, and you share responsibility with someone else. So we have half and half on the audience who is in charge of that. And about training, we just want to have the exposure of the training that you might have in CQM. And we have 27% have attended, but not very many. And here we are. So,
Great.
Michael.
It's so interesting because, like, in many settings, what we see is that we have around half of people are pretty experienced and half of people are pretty new. So, you know, we're going to continue doing that dance that we've been doing so far with you, where we're trying to help everybody here. We're trying to provide a baseline training for folks who are brand new, but we're also trying to have something for our more advanced folks as well. So really important context, and thank you so much for, answering that poll. Okay, so we're going to talk about clinical quality management plans. That's so much about what today is going to be focused on. And remembering what we had said before, Dallas County uses the ball and pedestal model for clinical quality management. And so what that means is we have our infrastructure, which supports quality improvement and quality measurement. And the two components for infrastructure are the CQM Plan and the CQM Committee. So we're going to be spending the first half of our session today really honing in on the QM Plan as the mechanism that brings our QM program to life. And the second half of the presentation this morning, we're going to be talking about the QM Committee. So there are a couple of important core components to CQM plans. We have our program infrastructure, which is really intended to be a thorough description of who's involved in our quality program. So that should include everyone who's involved in your quality program. You know, if you think about it, you have your CQM staff, but then all of your staff has a role in quality at your organization. So you'd want to make sure that you have descriptions for everyone in your plan. I believe it was last session, the July 6th session, we had sent you the revised Dallas County EMA and HSDA CQM plan, and you'll be able to see very clear descriptions there on where on what is happening in the staff and the team and how they play into the quality program. You'll also see that they include the Planning Council and the Dallas Task Force and other groups that are outside of what they do in their office, because those are really important aspects of the program infrastructure from their perspective. So similarly, within your agency, you should be thinking, do you have a CAB? Do you have a board of directors committee that focuses on quality? Do you have any other subdivision or group that focuses on quality? Oops. You want to make sure that your program infrastructure is really well described. Who's involved? What are the roles? Another thing to keep in mind is that the quality committee is described as part of your program infrastructure too, as we just emphasized in the last slide. So we'll want to have a detailed description of our quality committee and who's involved in our committee. And so what? What do they do with our quality work? Then, of course, we want to make sure that we're describing performance measurement, the methods for our data collection, our data reporting, our data synthesis, as it relates to the work that we're doing in quality management at our sites. This is really important to think about how all the different angles of quality come together. The Ryan-White HIV/AIDS program has been prolific in our field as far as the way that quality is described and the way that quality is enacted in practice. While there is really sophisticated literature out there from general healthcare, for the most part, most healthcare practitioners only do quality on a surface level, whereas Ryan-White really has pushed very hard to have a complete description of quality management. What we see is the ability for us to use the Ryan-White HIV/AIDS program framework for quality and to embed our prevention programs, our DIS programs, our STI programs, and other programs within our agency that relate to the HIV program and the patients that we're serving here. Finally, it's important for us to include a description of our quality improvement methodology. So there's a number of different methods that we're going to be describing through this series, and it's important to name the one that you've selected as your agency's primary quality improvement methodology, and to explain a little bit how the quality process works at your agency. Don't worry, we're going to be getting really into the details and the weeds on this as we go through the series, so you don't have to feel like you're needing to catch up. But it is really important to keep in mind that the quality improvement section needs to name a method and ideally would name the process by which you utilize that method, from including stakeholders, using your performance measurement data from a discovery standpoint, and then refining that data as you implement quality improvement projects. From the plan's perspective, the last important thing to keep in mind is that we have a work plan. And the work plan is one of the most critical attachments that you have to your CQM plan, because the work plan really is the way in which you're trying to concretely take steps to bring your quality program to life. Sometimes people try to attach this or append it directly to their plan, and we advise against that. We think that it's better to have your quality, your clinical quality management work plan separate as an attachment so that you can take it out and look at it separately, and there's much less pages involved with the documents that you're sharing back and forth and routinely using.
Michael?
Yes.
We have a question on the chat from Karen. Can you please elaborate on the role of the local Ryan-White Planning Council on QM and how this is integrated at the council level versus committee level?
That is a really great question, and that's getting into the mechanics of how we bring quality to life. So the Planning Council makes decisions related to priority setting and resource allocations, and it's important for them to have information related to the quality of care and the quality of services that have been purchased previously by the county, so that intelligent decisions could be made by that group in terms of what next steps to take, whether it is in redefining service categories or adjusting funding or we know how planning councils work, and there's a lot of different ways that they can touch on this. So basically the important aspect to keep in mind there is that we are looking at information sharing. You know, it's about making sure that information is available so that people can use it in the way that is most important. And what we do at the county level is that we have an internal committee that's made up of staff and an external committee that's made up of other stakeholders. You know, like the Dallas Task Force, Planning Council members, some subrecipients are part of that as well. And so quality committees are making decisions that drive quality process. The other groups like the task force and the Planning Council receive information that's communicated by the staff. So there's a fine line there between decision-making and authority versus consuming information that is available, made available by the quality team. I hope that answers your question. So getting back into the infrastructure and thinking about that, that piece of the quality plan, really what we're trying to do here is distill our quality culture and our quality goals. So our quality culture is embedded in the quality statement, and it really is thinking about the purpose statement behind your CQM program. And the way that these things should be aligned is that you have an organizational vision, and your organizational vision has a mission usually that helps to bring that vision to life. And those are tied to the quality statement, because you wouldn't want to have a purpose statement for your quality program that's completely out of whack from or misaligned with your organizational strategic plan, your organizational vision. Since a quality statement is aligned with your organizational vision, then it's much easier to have quality goals that are aligned with your organizational vision, because your quality goals will always be connected to your quality statement. Your quality goals should be considered interactive aspects of your plan. So basically, you're pursuing a question, or you're pursuing an ideal or a goal or an ideal state that you're trying to get to, and it should be something concrete and enough for people to sink their teeth into to make them excited about it. So some examples. At the county level, we're working on a number of operational quality projects, such as bringing online Qualtrics and qualitative review, such as reviewing our quality plan, updating it, and having more concrete attachments for people to bring quality to life in our county region. And in terms of thinking about the way that we do performance measurement and align our performance measurement with care markers and the HIV care continuum. In addition to quality goals that are more operational, of course, our federal partners are really interested in the clinical quality goals. So we wish to improve our viral suppression by a certain amount. We wish to address disparities to a certain degree. Being really concrete and specific about what your goals are and making them interactive in this way really helps to fire people's creativity and imagination. When we think about goals, especially when we start to pull apart those operational goals and the clinical goals, it's more important than ever to be judicious. In quality, we have a number of mantras, including be kind to yourself. So it's important that we're kind to ourselves and include only 2 to 3 goals per area, so that we are able to make sure that we're limited in our scope, and we're not spinning our wheels or stretching ourselves too thinly to actually make a difference. Really important to include in your infrastructure description is your leadership, your clinic leadership. The infrastructure section really should talk about the flow of authority and decision making. So it's really important that you include your key leaders. One of the ways that you can include your key leaders, because they're usually really busy, right? Because key leaders are busy like that, is that at the end of your plan drafting or plan revision process, you take it to your supervisor and you have them sign it. Including a signature page on the last page is a great way that you're able to emphasize your quality program, what you're trying to do, recent results, if you have any on hand, and then to get their buy-in for the following year. So getting their signature is a great way to make sure that you are getting that interaction, that feedback, and it should be a prompt then for them to say, hey, come talk to me in about 6 months. Staff involvement. As we mentioned, leadership is staff, and so staff should be mentioned. Usually they should be mentioned specifically, but we want to delineate the way in which staff are involved. So in having a section for all of your clinic staff is recommended. And then if needed, sometimes we might be a little repetitive from one description to the next because there's overlap, right? And the goal of the quality plan is to clearly communicate what it is that we're trying to do and how we're trying to do it. So it's really important that we include the quality management committee, QI teams. If we work in an agency that has, team-based work and everything functions based on teams, and we'll get to that in future sessions in the series. And the primary audience for staff experience evaluation. So again, thinking about all staff. What we're trying to do here is we're supporting language. We're trying to support language that's in most of our position descriptions, and we're also trying to make sure that our position descriptions are aligned for quality. So this is another opportunity to involve our leadership and our HR department to make sure that quality is included in all the position descriptions if it's not already, and that there are opportunities for us to evaluate staff based on their involvement in quality in our organizations. So the CQM committee, basically is the vehicle for bringing our quality management plan and our quality management program to life. An overall committee should be drawn from all quarters of your organization. So you're trying to think about all the stakeholders that are involved in your program. So staff at different levels, folks from different departments. If you are a multi-site organization, sorry, it says subrecipients, I should say, from other sites. If you're a multi-site organization, consumers, another group to include. And it should be, you know, going to the question about planning council versus committee, those lines of authority, the committee supports the staff. Basically, the staff are the wheels, you know, making the work come to life, you know, producing data, producing other things that can be consumed, reports and whatnot. And it's important that, you know, to remember that the quality committee is providing advice and guidance to the staff, but the committee doesn't drive the staff because the staff has its own set of bosses, right? You know, there's other lines of authority and communication. So it's important to see the committee as something that helps to support the activities of the QM staff and not the other way around. Some CQM committees have subcommittees. So in terms of thinking about our multi-site organizations or our huge organizations that have multiple service categories, sometimes you can think that way. It's really important though that we don't make so much process and structure that you know, it gets out of control. So in terms of thinking about the CQM committee, it's really important that it's completely laid out in the plan. So, you know, the members, you know, you want to include the roles. Sometimes you can include the names, but, you know, since there's turnover, it's better to include the role than the name usually. The functions, so they review data, they maintain the CQM plan, they process quality goals, do the evaluation, etc. The frequency and location of their meetings should be included in the description in the plan. How they determine quality projects. So oftentimes we're referring to the QI section, but we can even talk a little bit about the process of discovery, root cause analysis, change idea, prioritization, and then processing change ideas. And then they're responsible for analyzing the CQM plan evaluation. And I'll turn it over to Jamie to finish off this section.
Yeah, thanks, Michael. So let's talk a little bit about evaluation. And so this section of the plan is going to be similar to other areas in that it should outline your standard evaluation. So some questions that you would be asking would be, you know, for example, what is a logic model? What data are collected and analyzed as part of the evaluation process? How are changes made from year to year on the plan, and then like the activities, you know, within the plan that the plan is covering. And it's really important to include an emphasis on sustainability and make sure that sustainability is strongly emphasized here. Outline types of evaluation, and that could be internal findings that are based on your work plan. It could be findings or recommendations from, you know, HRSA HAB site visits and the like. An evaluation could also be based off of, you know, consumer feedback, staff feedback, and sort of those mechanisms. But another kind of key thing to keep in mind with evaluation is that, you know, when you're handing your plan off to be signed, you know, just having kind of that elevator speech, that sort of, you know, quick comment as to, you know, what evaluation is happening and occurring and what that feedback mechanism is telling you, that's important to include in that elevator speech to your organizational leadership. And I'll try advance. I might need you to advance. Thanks, Michael. Performance measurement. So this is actually like, I think, a really exciting component of a plan, but a lot of people I think can get bogged down a little bit. But the performance measurement, you know, this is a key activity that should be laid out in the plan to help formalize it. And it's really encouraged to maybe have kind of a short narrative paragraph that describes the process for measure selection, followed by a relatively simple table. You don't want this section of your plan to get, you know, really out of control or long-winded, which can happen, I think, when, you know, you fund a lot of different services in an EMA or a TGA. But the table really kind of it includes like the measures themselves, the frequency of collection and the data sources, and that the table just sort of informs CQM staff, subrecipients, what's needed to track the data and report it back. And then we also would recommend that following that sort of simple performance measurement table, there be a few sentences to identify where folks can turn with questions and concerns about performance measurement. We can go to the next slide. So quality improvement, the big picture, it's really just important. And also we learned from our first training in PCN 1502 that there be some sort of established methodology. So oftentimes, you know, the model for improvement is utilized especially amongst Ryan White HIV/AIDS programs across the country. Other methodologies such as lean and so forth, those are acceptable and used as well. But the model for improvement with the PDSA cycle is the most common route that we see. So some of the things within your quality improvement and within that methodology is the QI project selection. And this allows for a type of priority setting within the committee as to what QI projects to initiate and work on. QI project charters are super helpful documents. They really help guide the work, and they lend itself to writing up and sort of being able to summarize what's going on in the area. And I can share from experience that the QI project charters have also really helped prevent against like creeping in scope, where your QI project kind of just like creeps and gets a little large and you try and take on too much. You can always refer back to the QI project charter to keep the team centered. With your QI initiatives, you can also have a use of state level teams, and this allows participants to engage, at a state level or a regional level and align their interests and promote stronger buy-in and participation across the jurisdiction. And then your QI component would also cover the data management, which is going to include project reporting, training, capturing, and other activities related to quality improvement. Work plan. So Michael talked a little bit about this already, but we can't really emphasize enough how important the work plan really is. It's a guiding document to make sure that continual progress is made, and it has all the necessary and relevant areas tied together. A lot of folks use Excel, which I think is pretty awesome because you can structure things and you can organize them by month. It's super easy to identify who's responsible for what, when, and how it's going to happen. And some folks, because quality goals are aligned with your overall organizational values and strategic planning, it can be helpful to organize your work plan by quality goal. And this helps to improve communication with staff and other stakeholders involved in the work. Now I might hand it over to Oscar to talk a little bit about today's toolkit.
Thank you very much, Jamie. We have, we don't want to just give you this amount of information and you figure it out. We want to guide you into that, but we have some help as well. We have resources that you can have access to. And for instance, we have these three big groups, HRSA, the county, and the CQAI. But the Target HIV have the Quality Academy. They have a free 20-minute training that can give you to your team additional context. Can give you some extra skills, some improvement of your skills to gain some kind of like move forward your CQM program. Other than the Quality Academy, you have the NQC, which is now CQII, but they've been changing name, but it's the same idea of training and support the progress toward the CQM. It's that way is very, very helpful. Check it out. Locally, Dallas County at the Grain Management Division, we have developed at the CQM level checklist. The checklist is a guide. It's a guide to show you the way CQM plans take shape in our region. So this it's not a requirement, but help you to move forward with the requirements to be in compliance for the contract expectation and advance your quality program itself at the subrecipient level, at your level. The NQC and CQII, just to highlight the fact this is so rich and very good in information, and it's accessible to you. The Glass Cube will help you as well to collect that information, and you can access this in this website. And they have, as you've been receiving, the organizational assessment is the tool that we're going to be using. But what happened? There's a multiple tools. I remember one of you agency, we were asking about the organizational assessment. There's one for recipient, one for subrecipient, one for Part C, one for Part D. When you access that, click on the one that says Part C, D, that organizational assessment belongs to the subrecipient level. Why? Because you are direct service providers. That's a very good information for you to use, and it's accessible to you. And we're gonna have the Glass Cube as a guide for you to remember how to have access to those, how to reach that information that is rich in content and helpful to your agency and yourself. Thanks so much. Now we pass the microphone to Angie.
Thank you, Oscar. During a few of our training sessions, we'll have an opportunity to hear from a few of our subrecipients and highlight them, those who are doing great work. We won't have an opportunity to highlight everyone, unfortunately, but we will do a few of them. And today we'll hear from two of them. The first is Piper Duarte. She is the Performance Improvement Analyst at Parkland, and she's going to talk to us today about her CQM plan. Piper, you have the floor. And you can unmute yourself.
She just texted that her Zoom was having in and out issues.
So Michael, if she's unable to join us right now, do you want to move on and come back to her, or what would you want to do?
Sure. I see that she has a couple of logins though, so I don't know if maybe it's just an issue with the one. I don't know, but we can always circle back and get an update. We were hoping to hear our subrecipient spotlight before we break into our breakouts. Let me see. Let me just ask real fast. Yvette Chino, what organization are you with? Well, we're waiting just one more second to see if Piper can unmute.
Hi, can you guys hear me?
Hi, yes.
Okay, sorry, I was on mute and I didn't do it right. Hi, I'm with Parkland Hospital. I'm also with Piper.
Oh.
Hi, can you guys hear me?
Hi, yes, we
I see
can.
Piper now.
Okay, yay. I missed any introduction, but you know what, we're all together in this. So do you want to, let me go for answering the questions. No pressure whatsoever. Our plan has been in existence since far beyond when I joined the team 8 years ago. But if we're talking about our newest plan, we kind of did a redo in 2018 because previously it was just leadership. Leadership came to the table, leadership discussed the quality needed, the initiatives needed, the plan, and then kind of went and disseminated it to the group. And in 2018, we did a big overhaul to instead focus on frontline staff and kind of switch to what you were speaking to, where we got leadership buy-in and ownership and accountability, but we put more decision-making and autonomy with the staff and with the consumers. So we called it our relaunch. We dug in and with the help of our leadership kind of just reworked the plan to be more specific to our entire department, since quality is everybody together, not just me or those in each leadership position. So we did that in 2018. So what part of the plan are we most proud of? Well, you'll hear the other people on the call. It's our data. It's our ability to really dive in and look at our performance measures broken out to really build equity. So that's what I think is one of our biggest assets, is our data team is really responsive to the questions of clinicians, to the medical assistants, to the nurses that all have questions about, it'd be great to see what we were doing, and let's look at the different populations that we're serving. And is everyone being engaged equally? And if not, because we know that everyone is not, when they're not, how can we all break it apart? And the data team is very responsive in being able to break out those numbers by priority populations. Is what we kind of drill down to focus on. And then what are we most worried about? Scope creep. So we get really big ideas. We have really big gaps sometimes that sometimes seem too big to address in that quote unquote short period of a CQM plan. We typically have our plan cover a 2-year period of time where we evaluate it annually and we check the data quarterly, but we try and keep the plan itself relatively static and really hone in on having a timeline of efforts as an attachment that we can share, and then the work plan as attachments that we can share. Because since we're funded by several different entities, subrecipient through A and B and direct recipient with other, with C and D, we wanted to be mindful, and we used to have different plans, it felt like, that were disjunctured. That's not even a word. I just made that word up. I apologize. We wanted to pull everything together because we kept getting we get the most interface from the Dallas County CQM team, right? And so we're visiting with them, but our plan was really rooted in C and D. So it was nice over the last few years to kind of tie together and say, this is how this plan speaks to this funding and service categories. And then this is where the plan speaks to more specific efforts, whether it's early intervention services, Part D, routine testing, et cetera. And that's kind of our plan in a nutshell. I can't see Zoom anymore, so I'm not sure what the last question was. It's connecting me once again.
Technology, that's okay. It's a team-based approach, right? So
Yeah.
The last question was, how often do you update your plan? And I think that you already touched on that.
I did, but although we did shift, the biggest changes we've made is thanks Corona. It reminded us to put.
Oh.
You're muted now, Piper. It's
Okay, so last question before it cuts me off. I'm like getting the gong bell. So the biggest change we made for this plan was we made it inclusive of emergency management because it was important for us to know we were having to shift our care model so drastically from being all face-to-face and very minimally virtually to now very heavily virtually. We wanted staff to feel comfortable, consumers to feel comfortable. So we took some time to dig in and just link to all of our internal resources, what the county, and kind of make those links to where when we're sharing this plan that's just been signed to launch, we took an extra 3 months, told everybody, we're taking an extra 3 months. We'll launch the plan in July, for a new rehash for this most recent plan. And we'll make that inclusive of more direct resources to where any staff coming in, any staff joining, they can find out where those resources are as they're shifting. And that's it.
Great. Thank you so much for that presentation. Just a couple of quick takeaways that I had. I love that you are being judicious in the changes you make to your plan. Your plan is your quality program. And so you don't really need to make that many changes except for, especially if you don't include staff names, your process and your flow is your process and your flow. And, you may change your quality goals occasionally. There may be nuances to the performance measurement and the quality improvement aspects of it, but all of those changes would come incident to your evaluation and would be calculated and planned. So this speaks to the idea again of the importance of the attachments. In addition to a work plan, you can include a capacity building plan. I'm seeing Norma's note on telehealth, and Piper had just mentioned also trying to think about how you keep everything kind of at the front and center for people. So having discrete attachments, the performance measurement or the data collection plan sometimes might be another one that you would have as a separate attachment, because having an embedded table that takes up 20 pages just doesn't make sense. It just doesn't make sense. It's better to have something discrete that you can work with. So I really like everything that you said, and thanks for your great work.
Thanks.
Okay. So Regina, if you don't mind, I'm going to take the slide because I noticed that I wasn't able to assign myself to a room, which was an oversight on my part. So what we're going to do is we're going to have around 15 minutes to explore and dive in together, in different breakout groups, our own quality plan and our own quality process. And so, yeah, 2/3 of you are about to get a notice that you're being sucked into another room, and those of you who are staying here with me will be staying here with me. Okay. So the folks are going to the other room. I should have Angie, Brian, Claudia, Kim, Piper, Sandra, and Sonia with me. Okay.
Michael, did you hear, I think before when Piper had, was having technical difficulties, that Yvette or someone you asked what organization she was with? And I think she said she was with Parkland. Did you catch that?
Yeah.
Yes.
Okay.
Yes, Yvette is with us. All right, so what we want to do is basically explore with you. We just heard from Parkland. So I know that we have, you know, a couple of other folks on the line too, so we can give our colleagues at Parkland a break. But, you know, did you hear anything new from this morning's training that made you think about your quality plan? I know that we had the more advanced group of providers here in this first breakout session. So I just wanted to ask first, you know, what did you learn from this morning's peer presentation and training? And what are some of the new understandings that you have around your quality plan, if any at all?
Excuse me, Michael, before you get started, who should be in our group and who should we see?
We should see me, you, Brian, Claudia, Kim, Piper, Sandra, and Sonia.
Okay, because I see Oscar. So Oscar, okay, now I know.
Oh,
okay,
you didn't go to the other room. Okay.
Okay.
There we go.
Thank you.
Thank you so much for checking on that. I'm sure that they missed him in the other room. Great. So what do we think? Did you learn anything new from this morning's presentation, or did anything strike you? Did you have any ahas about quality plans?
Hi,
feel-
my name is Sandra.
Hey, Sandra.
Sorry. Oh, hi. My name is Sandra Najuna. I'm with AIDS Healthcare Foundation. I learned two things, and the first one that sticks out is actually with the Piper's presentation. I hadn't thought about, I've actually been thinking about like, what does, how is COVID going to impact how we write our QM plans? Then initially I was like, it's not HIV, so I don't know if we should really adjust the whole plan to accommodate COVID. But then, yeah, I realized that it's important now to look through my, whatever it is I wrote down and see if it actually caters for the new way of giving care to our patients going forward. So that's something I should think about and edit. And then for the most part, we already have a work plan that actually has most of these categories. But then I had about using an Excel sheet. Then I realized that I've had this conflict with writing my plan, because my work plan also has a program description. And again, based on what Piper said, I also try to have my work plan and the program description together. So I can't really use Excel. I use Word, though I have a table for the work plan, but I have the rest in a program description so that I can be able to outline like the capacity building and evaluation, which you can't really, I mean, I guess you can outline it in Excel, but it would be a very long table. And then I have the work plan as a table, which would look like it would be in Excel, but I then have to have everything in Word so that the work plan, the program description is all together in this one document. Yeah, that's all.
Thanks so much for that. There is a lot to unpack there, Sandra, and I think that you're right that it's really great to include things like COVID. You know, these external pieces that come in that shock our work and shock our environment are really important. You know, what's really interesting is my friends in New Jersey are actually including social justice in their quality plans as well, and helping people to unpack Black Lives Matters and, you know, the amazing social justice discussion that's happening in our culture at this moment, you know, is a really great time. So much about quality, as we've been, you know, alluding to, and we'll dive into more deeply, is going to be about stakeholder involvement and, you know, thinking about all of the people on our team and all of the people that we serve and how life touches our work. You know, I think it is really important. So there's some really neat stuff coming down the pipeline in terms of how to shake out some of these nuances and to make sure that we can still be clearly focused on HIV while taking into account all these other really important things that are happening in the world around us. You know, to your point around Excel versus Word, and the calculation of results and how you end up manipulating data so that it best suits your needs. We have a couple of templates available for the capacity building plan that's in Excel. And we can also share some templates that we've used in the past for evaluation as well. And so this should definitely be looked at as like a giant learning laboratory. Sharing is caring, right? And there's going to be different things that work better for different organizations in different settings. But that's not to say that we can't learn from each other and potentially borrow. What do we like to say in quality? To steal shamelessly and borrow senselessly, right? Hey,
Yeah.
there we go. So yeah. Does anyone else want to share some ahas from this morning? Oop,
Yep.
I think you're muted, Piper.
Piper.
Gosh, I'll get it right one day. Even though I feel like I'm the nerd in the room most days where it's always like, yes, 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 but I still every time take away something different. And even just in being more nuanced with our capacity building, right? And then being more nuanced with how those discrete attachments that you discuss, you know, what's more palatable? How can people best digest the information? Because so many times I live it every day. I'm living in the paragraphs, I'm living in the narrative, I'm living in the data. And then I visit with our frontline workers and that's not their priority. Our patients are everyone's priority, but it's just a different lens and making sure that I'm being inclusive of their experience and expertise, and then making all of my diatribes and our efforts and our needs and the goals digestible. So yeah, that's definitely a takeaway, is more discrete attachments that can be digested easily.
I love that. You eat the elephant one bite at a time, right?
Mm-hmm.
There's no other way. There's no other way. Great. So in terms of thinking about the challenges that we faced collectively in writing our quality plans, I just wanted to see, you know, if anyone wants to share what if they've had challenges and what those challenges often are. So maybe we can workshop that together for about 5 minutes. What challenges have we faced? There's space for everyone at the table, so I want to make sure that I hear from a couple other folks too. Muted. Let me see if I can unmute some folks here. Claudia and Kim, I'm asking to unmute you so you can share with us. What are some of the challenges that you've had in writing your plan or bringing your plan to life?
Michael, someone's in the waiting room too. I think 2 people, if you see that or not.
Here's Dell. Yes, thank you.
Mm-hmm.
Well, this is Kim with Health Services of North Texas.
Hey, Kim.
When I started, we already had our quality plan, but I was one of the ones that helped update it last summer before it went to the board. So it was like going through and picking out everything that, oh, hey, we don't do this anymore. Do we need to keep doing it, or is this something we need to update? And I feel like we did a really good job. We added things that we didn't have in there before. Ours is more than just the Ryan White part. It covers our whole agency. So we added in the measurements that we use for Title X. That was one of the things we added. So it was just kind of it was a good learning experience for me to see to actually read the whole thing word for word and stay awake and be able to look at it objectively and say, hey, we're not doing that anymore. We need to get back to this, or hey, we need to update this. This is out of date.
I think that that's so important, you know, and definitely speaks to, you know, what Piper had mentioned before in terms of like scope creep, right? Like it's really easy to be passionate people and to care a lot about the work that we're doing together and to say, oh, well, we can't take anything off because it's also important. We all care very much about our patients, and that's why this material is here to begin with. So why would we take it out? You know, and having that conversation and having that ability to think about evolution and how, you know, the problem that you worked on yesterday is still something to keep in mind, but it's going to take a different form as we move into the future, you know, and then updating and taking that baby step, it can be really hard. I don't know if you have any advice to others who are facing that, Kim, and how they might try to structure that type of conversation with their leadership.
Well, I think what helped is it wasn't just one or two people. We had input from other people. It was mainly me and Louise going through it, but we took, okay, this part really needs to go to our clinic manager to look at it and see what needs to be changed. And that's how we ended up adding Title 10. That was her suggestion. And at the same time, and I don't know if this was smart or punishment, but we went through all of our agency policies. We were going through updating those. So it was a fun summer.
Oh yeah. You know, the policy and procedure updating, like the process mapping piece is something that is more on the administrative side than the clinical quality management side from the Ryan White standpoint. But from the global standpoint of quality, it's so important to make sure that we understand how our process works and what foot goes in front of the next.
Yeah, and that is, from that point forward, the policy part's going to be an ongoing process for us.
Thank you so much. So I'm wondering, we only have about 2 minutes left, but I'm wondering if anyone wants to share, if you were to meet someone at a conference and you found that it's their first day on the job, what advice would you give to them? No takers?
Hi, this is Sandra. I'll take it.
All right, cool. Thanks, Sandra.
So what I'll tell them is something I've learned on my journey of quality management, which also works for the work plans. Like, unlike compliance where everything is like set in stone and this is what you have to do, quality management is a living, it's like a living document in essence. So the work plan is a living document. So you have to be open to the fact that what you have in place is not what is perfect, but when you listen to the stakeholders, whether it's the staff you work with or the consumers, you edit or you change what your perception of quality improvement is every time. And you have to learn to be okay with that. So it's not something really, it's very dynamic. It's not static. So like every time you hear about something, I'm national. I work in like maybe 18 other states. And you know, one day you learn something from Florida and like, I think this would work for our plan in Texas. Then you add it on there. So it's just being okay with not being okay in a sense, but trying to build something that works best for your staff and your consumers. So I'll tell them.
Oh man, is that ever important? Like our passion can be something that is a real benefit to us, but it can also, you know, put on the brakes when we become so passionate about something that we've married ourselves to it. And our hopes and dreams and successes are tied to this document and how well it's brought to life. It's really hard to resist that urge, but it's really important that we do resist it because we need to help other people along over these humps because they're going to experience the same psychological hump we do. And if we're not there to model that type of maturity and forward thinking, evolving, you know, piece, then we're not going to be serving anyone well.
True.
So I don't know, we have about 60 seconds. Folks will be cycling back into our room, but does anyone else want to share any last thoughts on advice for new folks in the field?
Welcome back.
Welcome back.
Oh, we're getting a song. Okay, I like it. I know our group just kind of popped back in, but I think we had some good notes on that question. Like, what advice would we give to somebody? I think we had some good discussion on that.
Cool. We'll see when Oscar's group gets back, then we'll pull the slide up and do some debriefing. Okay, and everyone should be back now. Okay, do we see the slides again?
Yes.
Yes.
Mhm.
Okay, so let's just do some quick report outs. Angie, do you mind reporting out what we discussed in our group?
Sure, sure. We kind of talked about some things that were learned with the session so far and different presentations. And so some of the things that were talked about were that our CQM plans can focus on HIV, but take into account other things that's going on in the world, like COVID and the social justice movement, Black Lives Matters movement. We also talked about different formatting for the work plans. Some people use Word documents, and in the presentation, Excel was brought up. And so that was discussed about how to use Excel to build and improve the template of the work plan, and as well as using a capacity building plan template and a program evaluation template. And then we talked about a kind of bringing the CQM plan to life in an easily digestible manner, which makes it very easy for staff to understand and stay on top of what's going on. We talked about updating and revamping the plan to reflect the reality and current processes, and so not to stay doing something that's not actually happening, you know, but if it's something you're supposed to be doing, to begin to start doing it. And if it's something that isn't relevant or shouldn't be happening, to take it out and just make it to reflect the new changes or the accurate reality. And then we talked about it, you know, what some people would tell new staff starting out. And one of the main things was just that CQM is fluid. It's not black and white like compliance and some issues, and that just to be open to change and moving the ball forward. So that's kind of it in a nutshell. Do you have anything else you want to add?
No, that sounds like it's about it. We had a great conversation in group one. Thanks, Angie. Sorry, Oscar, I didn't mean to usurp your task here, but I'll finish out calling up the recalls and turn it back over to you on the next slide. Regina, can you debrief what you discussed in group two?
Sure. So an overall consensus is that COVID-19 has really put some challenges out there for quite a few of the agencies. That, you know, now it's time to, you're having to look back and maybe make some changes and bringing other individuals on board and understanding the difference in QI and QM. And so, but one good thing that was mentioned that it has been the performance measures, being able to share those with not only the staff, but with the clients as well, which is part of a team. And I'm speaking more specifically to ASD right now, and having them, they're enjoying or receiving information on the performance measures monthly now. So the committee is meeting monthly, and now they had to go to Zoom to have those, but they've gone from a group of 10 to a group of 20 individuals. So that really has helped. Let's see, and then we talked a little bit about changes in staff has been a big challenge for a lot of agencies as well. Going from maybe not having a person for an extended period of time, or having a lapse in staff, or you know, the shift, moving from one individual to the next, and then that person learning the role, the quality and performance measure role. There's been some changes in work plans and some struggles going on with everyone working from home since March. Early March, so just trying to work on moving towards having a plan. And what was suggested as far as maybe bringing on when a new person coming on, there was really reaching out to individuals with the skill set of data and knowing how to put Excel spreadsheets together and things like that. So using all the resources that are available to you. And of course, Target HIV was mentioned, and HSDA's website was mentioned as well. Team, am I missing anything? Jamie, anything you want to highlight? Anybody in our group? Did I miss anything? Okay, that was it for us.
Thanks so much. And rounding us out, Julie, for group 3.
Sure. So we had some great quality leaders in group 3. We had folks from PRISM, folks from the Cali Clinic, and Dell from the Resource Center. So we could have talked a lot longer, actually. So PRISM shared some great advice. Actually, let me start from the beginning. So when they kind of also revamped in 2018, but they already had a strong infrastructure. They already had a QM plan in place and a committee in place. So when they got some new staff involved in QM, it was easy for them to just pick up the ball, so to speak. Some of the tips that they shared that helped them a lot are to use realistic and manageable, achievable goals. They had some goals that seemed, they were like scoring in the 60s with the goal being in the high 90s, and no movement was being made. After they lowered the goal and changed some of the activities around it, they were able to achieve the smaller, goals and then gradually move up, and now they are in the 90s. So that's great advice not to set your target too high. They also shared how they have such a great involvement from all of the stakeholders, including leadership, consumers. They're very active with their CAB and have a great staff that's always willing to participate in the QM projects and the committee. Norma from the Cali Clinic talked a little bit about how they implemented telehealth into their CQM program and CQM plan before COVID hit. So they have actually been leading Texas in telehealth, and how they've implemented some patient satisfaction surveys that each client gets right after their visit, and they've all been very positive. This has really helped them to improve access to care, considering they are located in a very rural area, and the surrounding areas are also, they have a lot of challenges with having infectious disease doctors, so they were able to come up with an innovative way of contracting with a physician in Dallas who does the telemedicine and telehealth for them at the Cali Clinic, and has led us with the great ideas that they've done. They've developed a policy, they've developed several tools that they've shared throughout the state. And we actually ran out of time before we got to hear from Dell. And there's actually more stuff, so please feel free to speak up, guys who are in the group, if I misspoke at all or forgot something that was really amazing. Or Oscar.
Oh, well, no, you couldn't describe it better than that. I mean, that was the panel and the discussion. Actually, we needed more time on that. Yeah, because the new were Natasha, Julie, and myself. So, but the rest of the panel, you were full experience and fantastic input on that. So, what is coming is now is a question on the screen. That two questions: are you involved in your subrecipient organization CQM committee? It's a yes or no, don't know. And how many training have you participated in regarding the CQM committee?
The votes are pouring in.
Answer are coming.
Should Ryan and I participate in these questions, or that would like alter the results, right?
Quit skewing our results.
Okay, we won't.
Thanks, Julie. All right, and I'm just going to go ahead and share the results here, Oscar.
All right, we have the involvement I said, yes, it's 82%. I mean, it is 82% of our participants were involved in the subrecipients CQM Committee. Just 8% are not, and 8% not sure, don't know if they are involved or not. In the training that have participated in regard to CQM committees, this is the first one, 17% is the first one, but the majority are not very many, which is ranging between 1 and 3. And those who are being in way too many is 42%. Okay, I hope that if you know someone you remember, if you learn something, use it and enjoy it, because this is coming beautiful. Thanks so much for the polling and the answering the questions. But Michael?
Thanks, Oscar. And it's great. It's interesting to see, as I turn it over to Jamie to walk through the next section, it's really interesting to see that we actually have a little bit more experience in training on committees than on plans based on my reading of the data. So it's really interesting to know, and we're excited to continue the presentation.
Yeah, thanks, Michael. So let's switch gears and let's talk about the Quality Management Committee. So the committee is actually going to be that second infrastructure component in conjunction with the QM plan that supports the overall activities. We can advance to the next slide. So what's the purpose? So it's really important to understand that the Quality Management Committee, it's advisory in nature. Nothing is carved in stone. It is super important to have transparency, especially as you'll be looking at data and prioritizing projects and evaluating yourself and sort of continuously making progress. One of the key activities is to review that performance measurement data and then to make those recommendations. One of the coolest things, and I think as a person and as a professional, is that your CQM committee can be a space that's unlike any other, where you have an opportunity for peer learning and sharing best practices. And it can kind of be this learning lab where you can fail forward, where you can ask questions and you can share ideas. And I think that that can make it a really great dynamic. We can advance to the next slide, please. Something to keep in mind, and we'll remind you about probably a lot throughout this training series, is that quality improvement and those activities are not grant administration. So it's really important, you want to be protective of your committee, and you want to make sure that the committee is focused on improving health outcomes, because that is the split between what is quality improvement, what is quality assurance. So the intent of grant administration is not to improve health outcomes, and therefore those kind of administrative activities shouldn't be done within the responsibility and roles of the CQM committee. Next slide. So the structure, so we heard some really great discussion on this in our breakout, actually, when we were talking about the plans, and I'm excited to hear from the second breakout today. But just a reminder, you want to pull from all kind of corners of your organization, and you want to involve all stakeholders. So this could be subrecipients, this could be the, Part A, Part B staff, this could also be clients and different members who maybe also sit on planning council or patient advisory boards, et cetera, et cetera. But the structure includes meeting regularly. Again, your work plan driven, because that's kind of a guiding document that keeps you accountable and helps you measure change and progress over time. The structure should be described fully in the plan. Who are the members? How are they trained? What kind of capacity building opportunities exist? And then how does the committee interact with other relevant structures? Maybe within your agency, there's other quality groups. If you're maybe at a larger, clinic-based hospital or something like that, maybe how do they interact with your planning council or the Dallas task force, et cetera, et cetera. And then how are decisions made that affect quality management? And we have that picture of the tree. It's sort of like, with your committee, you can see over time your growth and your change and sort of, where you started and then, where you've ended up, which can be a really meaningful journey. We can go to the next slide, please. So, are we on membership? Okay, so it is kind of advised to not have more than 15 members. I think what we learned from an example earlier, of one agency, one entity going from 10 to 20 is how inclusive that was. And part of that reason for that number was the engagement of clients, which brought in meaningful voice, which is really important. So essentially, you just want to make sure that there is a consistent and diverse population, and that consumers are part of the committee, And you can also have a parallel interaction, like maybe with a consumer advisory or planning council or patient advisory or other group. It's okay to not have subcommittees to start. That might be where you're at. You don't want to over encumber people to be sitting on too many, but eventually you might get to that point for capacity, capacity building, data subcommittee, so forth and so on. Next slide, please. Performance measurement. Again, the purpose, one of the key activities of the committee is to review data. So, you know, you can ask yourself, how often are we doing that? Are we doing that with consistency? Where could we grow? This might be an opportunity for growth. You can never be too transparent, right? Part of the function of the committee is to look at the data so that you can identify areas for opportunity and you can truly understand where positive change is taking place. So data would be curated by the AA CQM team so you can find focus areas. And we heard earlier from our first site spotlight about the power of segmentation and looking and stratifying the data so you can evaluate health equity. That was a fantastic example that I was like, this is going to lend itself so well into future slides. So examining those disparities and looking for opportunities for cross-agency learning and really amplifying quality champions. Quality improvement. So it's important that the committee get the opportunity to be trained in these methods. Absolutely, none of us know what we know if we hadn't been trained and we hadn't learned along the way. So it's super important to include that. And we talked earlier about making sure all QI projects are structured with some type of methodology, whether that be the model for improvement in a PDSA format. And this helps identify what activities are going to be tied to the overall EMA HSDA. And then is anything happening at the state level that's maybe beyond? And is there a way for alignment? Is there opportunity for more trainings? And finally, you want to make sure all your QI projects are selected based on data and priorities and the relevance. And that selection and alignment of priorities is one of those key functions that the committee can lend to the jurisdiction. And work plan, here we are talking about a work plan again. Again, this is a super efficient method for tracking tasks. We had some shout outs to some really proficient Excel members in our first breakout. So, you know, utilize your team's strengths and engage people who are maybe super talented at that, because this is a really powerful communication tool. And again, just to reiterate, the important tasks on that work plan would be your data reviews and your presentations, which touches on, you know, how does this group communicate with outside groups and parallel groups? Your QI project discussion, you know, priority setting and selection, when does that happen in a given year? And then what are the different QI project updates and the reports associated, the PDSAs, the data reviews, et cetera, associated with those QI projects. And you can never overlook the need for training and capacity building for new or even ongoing membership. Michael.
Great. So now we're going to switch gears a little bit and talk specifically about how the magic happens, right? Because I think so many of us have been like, all right, let there be a committee. And now all of a sudden there's a table with people around it. And instead of being focused seriously on work and how to advance the work forward, we get stuck in other things. So this is a graphic that I like to use to show how we can leverage our stakeholders. And I'm going to take a minute or so to unpack it with you. Above on the left side, we can see all the different data sources that we have coming together for our decision-making, digestion, and conversation purposes. We have clinical data, we have funding data, we have patient care experiences, risk and behavior data, recommendations that come in from the field. And when we think about this, these data sources come from all over the place. They might be coming right out of our health record. They might be coming from finance. They might be coming from town halls or community fora or a comment box. They might be coming from our prevention program. They might be coming from our disease intervention specialists. There are many different areas that these data can come from. And the slide is good because it's meant to help you kind of think about all those various sources of data and where they might come from. So we have a work group or committee that takes all this information and discusses it. You know, one piece of data relative to another piece of data do we have apples to apples, or can we at least make some kind of overarching assumption about what's actually happening for our patients and the services we're providing based on the data that we see in front of us? So our committee then makes recommendations and that go up to higher levels. So thinking about a Part A, which we're a part of, at the county level, the conversations that happen within the county then go to the planning council or to other groups to make bigger decisions on what we're going to end up, what future steps to take. For quality, this may be a quality board of directors level, or it may just be our boss. But the idea here is that the functional group of people working on quality is then that work product is taken by the quality staff to another group to make final decisions. In terms of thinking about what all this means, we have QI activities that come out, basically, right? That's really what we're focused on here. The data might tell us all kinds of things, that we might make decisions that are based on activities outside of quality, but we should probably stay focused on quality to the extent possible. And so how do we do that? We need to provide training to folks, especially when we think about our work group or committee as involving a range of stakeholders. If we have a cross-section of staff and consumers, that means that we may have some folks that haven't graduated high school and other folks that have alphabet soup after their name. And so we need to make sure that people are confident and comfortable in the subject matter and making sure that they can push back on each other. I'm sure that many of us have been in the position of trying to push back against someone who is more experienced or seasoned in a topic than we are, and how awkward that feels. So think about it from the perspective of a consumer on your committee. It's really important to make sure that we provide them with the tools that help them to feel comfortable and confident to weigh in a substantial, significant way. The discussion that we have that comes from our training background, and then also all of the information and the data that we're reviewing, is then used in a discovery process to generate change ideas. And we'll talk about this at length as we get further into the series and think about how we take a problem, study the problem, and then come up with solutions that are practical and timely based on our findings. These change ideas really are the nut of our quality activities. And when we implement them through PDSA cycles and the methods that we have in place for our subrecipients, that's where the QI activity magic happens. So this is a simple slide, but it's also a dense slide that takes into account the idea that we need to train people to have meaningful discussion that generates practical change ideas, and that everyone from the stakeholder standpoint is brought to the same level of understanding, confidence, and capability. So there's a number of different opportunities for engagement when we think about all the different stakeholders that we have, in front of us. We have our CQM committee. That's a really great way to engage folks, but we also probably have consumer involvement mechanisms, whether it's a CAB or a CAG or some other group of folks that is involved. Sometimes we have community involvement from faith-based groups, depending on where we are. Or we might have groups of mothers or young mothers, depending on where we are. We might have groups of immigrants. It's really important to think about all those different community groups and how you work with them, and to make sure that there's a place for them at the quality table. These are listed separately from the CQM committee because we may not always have roles or opportunity for all groups to participate in the CQM committee. And that's why, reflecting back to our earlier part of the day, thinking about the QM plan, make sure that all of these different groups are included so that we have an opportunity to see and to consider how they can all play into quality if there's not a direct space at the table for them to be part of the CQM team. Other planning groups that we should think about are the Planning Council, HIV planning groups, ending the HIV epidemic planning groups, fast track city planning groups. Lord knows that there's a lot going on in Dallas right now between Achieving Together, ending the epidemic, fast track cities, so on and so forth. So it's really important for us to think about how all of these different initiatives play into our quality program as well. And again, there might be a separate planning group for these initiatives, And it's important for us in our quality plan and to think about how our quality committee interacts with that. So if I am on a planning council, and I used to do this when I was the director of quality at Whitman Walker in Washington, DC, I sat on the planning council, and so our quality plan included the planning council because it was an important opportunity for our agency, Whitman Walker, to be learning about what's happening at other agencies and to be at the cutting edge of the direction that winds are blowing in the Washington, DC metro area. It was also then an opportunity for us to talk about how we can share out into the planning council all the great work happening at Whitman Walker. And so from a bottom line standpoint, a business standpoint, which many of us, you know, are working for businesses, right? You know, it's important to keep in mind what some of our leaders' goals are as well. In other words, make sure that we have the opportunity for the dog and pony show where it is welcome and warranted. So in terms of thinking about all the moving pieces that we've talked about and, you know, where we've had our training so far and what experiences we shared in our breakout, it's really important to remember that we're getting this training, but we've been trained on this before, and we have all the components here. We have our passionate stakeholders, we have tons of quantitative data available to us, and we have ever-growing sources of qualitative data, thinking about you know, the process that Norma has in place, but also the adventure that we're going to be embarking on together as the EMA and HSDA as a whole as well. So in terms of thinking about you know, our next steps, what we're just trying to do through this series is connect the dots for you. And we started talking today more in depth about infrastructure, but ultimately we're trying to think about this from a broad level as well. And we're really exciting to think about this engagement that we're doing with you in terms of a presentation and a breakout. A presentation and a breakout is working for you so far because we certainly planning on doing more of the same. And we're running low on time, so I'm not going to spend too much time on it. But one of my favorite ways to teach flowcharts is song flowcharts. So yeah, basically what we're trying to say here tonight is that we need you more than ever. Turn around bright eyes, and we won't fall apart. We've got this. All right, so I'm going to turn it over to Angie to introduce our next subrecipient spotlight. Angie?
Thanks, Michael. So our final subrecipient spotlight today is going to be from Natasha Chiafalo. She is the Analytics and Innovation Director at PRISM, and she's going to speak to us today about her CQM committee. Okay, Natasha, you can unmute yourself and the floor is yours.
Oh, well, thank you. Well, as I mentioned in our smaller groups, when I already came on board in October 2018, a lot of the infrastructure and history was already set in place. And I believe Del Wilson was really the forefather of the CQM program at Prism Health North Texas. So I just had to give that credit where credit is due. So when I came on board, I was looking at performance over the past few years. So sorry, to answer the first question, question number one, I believe it's been 9 or 10 years that our committee has been in place. And the greatest strengths really was the infrastructure, the committee, the support from the executive leadership, as well as participation of patient-facing staff in the committee as well. So we have executive participation, middle management, and patient-facing staff in the committee. And virtually all of the service categories are represented, including our CAB, and we desire to include more CAB members as well into the committee itself. But whatever happens with the committee also gets shared with the CAB. So we include the CAB as much as possible. And our membership and our participation does not change at each meeting because we have an established committee by the time the calendar year starts. And we ensure that we have all the stakeholders present in the committee level, but for our projects and PDSAs, we'll include more patient-facing staff for those individual projects. I've tried to not spread everybody too thin. So I think, so that'll go back to question number 2 now. The greatest strengths would be our comprehensiveness and a weakness that I tend to I always have to pull in those reins. Like, okay, let's not spread ourselves too thin. Let's not spread staff too thin. If there's meetings that, you know, we can have initial planning meetings and then from there go into more involved meetings later on with staff when you can shadow them. So I try to break everything down into manageable pieces, because if not, then it feels like you're eating a 16-ounce hamburger in one bite. And the same would go for goal setting. If we're going to be putting in the plan that we have a certain goal, I encourage people to ask, do we already have a mechanism in place to measure that? Because if not, then you're going to probably spend a year to build the mechanism to measure what it is you're trying to achieve. So those things, how can we measure? So before setting a goal, are we able to measure it? Where are we performing at the moment? If we were to make small changes that we can within a year, are we going to see X amount of change that we want? If not, how can we scale back? So we've been, myself and Joseph Iyongo work with each individual group to see what's attainable. So I'm all about starting small, which is not popular sometimes, because, you know, we want to make big sweeping changes, but it's, you got to start one step at a time.
Okay, thank you so much for sharing that with us, Natasha. Did you want to add anything else, Michael?
No, I just wanted to say it's really great to hear that you are relatively set in who is on your committee. You have a roster, and that probably is part of your evaluation process then, like in terms of identifying, you know, from year to year who stays and, you know, who's time to cycle off. And it's really wonderful to hear that your QI teams then offer the opportunity for broader inclusion of meaningful participation in your quality program. I'm sure that that's appreciated by the staff.
Mm-hmm. Okay, so thank you so much. And we'll go next to Regina.
I guess coming off mute might help, huh? Okay.
Details.
Details. Okay, so now we will be heading into our second breakout session for today, closing out, wrapping this up, and we're going to talk about the committees within our group. So you will be invited in to join a breakout session, and then, as I mentioned before, it'll be sucked back in at the end of time, even if you don't push it. I'm headed back in. You go back in to the main session and to the main room. So,
thanks, Regina.
Michael, yeah.
Click join.
All right.
All right. And here's our little work group again. And I'm sure that we'll emphasize this again, but like we're trying to make sure that from session to session, we have different folks in the breakout. So you don't get to, you know, you get to interact with different people every time. So hopefully this will be fun. From session to session, it'll be the same group like in each session, but from session to session, it'll vary. So. All right, so similar questions to what we had the first time in terms of thinking about, you know, we're a seasoned group of people. we've been parts of committees for a while. We've probably led them, you know, but in terms of thinking about the presentation that we just had and also Natasha's piece, are there any ahas that stand out for folks in terms of, you know, your learning or thinking in this area?
I know people don't want to hear my voice all the time. But that said, it is really good when Natasha was speaking to a QM committee and then more breakout inclusive QI groups. It gives that space to round out and not burn out. The burnout is a huge piece. You have champions that you know from the beginning are just, they'll always have these great ideas. They'll always put in the work, but you really want everyone involved in it and everyone to feel the positive impact when they make those subtle shifts. So that's a takeaway for me.
Yeah. I don't know if you have any strategies or suggestions that you would recommend based on your experience, Piper, in doing this, because I know that that's one of the things that's really hard, right? Like it goes to that passion point again, like the people that want to be champions are like, I'm here for this, you know, and like helping them to kind of make sure that they don't overcommit themselves or overextend themselves, I think is really challenging sometimes, especially some people just want to take it and run the whole way.
True. So one of the ways I've gotten more voices to kind of provide input is, so we have this meeting, everyone feels a certain comfort level. I always make sure and send out, I've created some surveys that we can send out via SurveyMonkey that then just kind of give them an anonymous space to kind of comment, weigh in, especially when we're doing evaluation of like feasibility of attacking a project, or, you know, feasibility of what goals we should be prioritizing. I've found that after we have the round table or a formal meeting, to have a survey, I can then get some additional input that I might not have received at the table. And people have, now that they know that that survey is coming, it's made the conversation at the table more bold, but it's also, we get some great feedback. And I find secret champions that way as well. Same with the CAB. Usually the biggest people who voice complaints or issues or concerns probably have a really good idea of what we could do to shift that and make it a positive. So don't always take the naysayers as a bad thing. We need to hear all of our gaps and opportunities for growth, right? Those growth opportunities. Even though it can be hard to hear.
I love that you mentioned that, because that's one of my favorite ways to engage people too, is to, you know, do some type of mini presentation, and then there can be like a round robin of reactions, and then to let people, you know, kind of like chew on it and digest it, to ruminate, so to speak, and then to kind of share back out. I think that that's wonderful. And, you know, fireproofing controversial ideas or ideas that conversely feel weak, you know, like, is this all we can do? You know, I think is a really great question. And, you know, kind of building on what we had spoken about this morning, COVID is a great environment to kind of practice this because the newness of it. You know, I know that for folks in our environments, you know, we probably have some providers and some leaders who are like, you know, for lack of a better term, like, wow, COVID is so exciting because we haven't had the chance to really practice this type of epidemiology, this type of infectious disease work in a long time. And so we can actually set up our little Prince net there and like grab that comment, you know, and go along for the ride. Similar with some of the social justice work that's happening in Black Lives Matters, you know, and those conversations about how the experiences of our staff and patients actually lend themselves to endpoint outcomes. I think, you know, that's another great, you know, opportunity to do something like this. Thanks so much, Piper, for sharing. I don't know if Kim or Sandra or Eddie, if you want to share. Eddie, I think you're in the wrong group. But I don't know, Kim or Sandra, if there's anything you want to share. Go ahead, Sandra.
Hi, this is Sandra. First of all, I apologize for any kind of background sound because I'm in California and I'm just driving to work right now. So if you can hear me, great. That I'm following on the phone, but you know. Anyway, yeah. So my involving staff, I feel like I've been able to, like considering staff as stakeholders. I think I'm getting there with them. It's been about building relationships with them because there'll be a time they need you for something. So just making sure I deliver when they need me, and kind of get that buy-in so that when I need something from them, they you know, they will work with me. And when I just started my role as a QI person, I would admit it was not as easy as much as this is something that's supposed to be doing, but building those relationships with them, I'm in a much better place. I've learned to like build data presentation tools, whether they have to be like very visual or graphical, or just to reel them in and show them the numbers, but like in an interesting way, and present projects in ways that are very practical and look like we're making it look so much easier than it would look like complicated. So with staff and even upper management buy-in, like just between developing tools that I know would make it easier for them to understand what the problem is at hand, And I've done a lot. I've gone as far as even having a heat map so that my presentations look like a CNN news piece on Wolf Blitzer's program or something, but
Exactly.
the whole bit. But then I guess it's a work in progress with clients, because we, like, you have I don't run the client advisory board, but we had staff that were really good at running the client advisory board. So once they leave, then you have to, work through the dynamic to get staff again that clients will respond to. And just I've been trying to build something that's more like a structure that's not affected by someone leaving. And just when we're working on it is when COVID started. So we had to like shelve that so that we can look at, telehealth and everything else, that the changes that had to go on with COVID. So involving the clients, we're not really there yet where it's super perfect, but it's getting there we're getting there with staff involvement. So we're hoping to take that journey with clients and be able to figure out grant advisory boards. I mean, we have many other ways to get feedback from them, like surveys and all that, but the client advisory boards are still, a work in progress. Then, as I think Paige shared about having a survey for staff. I'm working on that. I'm glad to hear her talk about it. I've been trying to develop that in SurveyMonkey so that I can send that out and see how comfortable they are, because I've received a lot of feedback over time, and it has improved my tools so much just from the way staff want to see things. So I'm going to have that formal process as well and send out a survey and see what they think.
I love it. So much about this is about people. Yes, Piper, definitely, yeah. Relationships. And just like anybody else, we get out of bed in the morning, right? And sometimes it's really easy, and sometimes it's not easy to get out of bed in the morning. And so the more that we keep our own humanity in mind, the easier it is to remember other people's humanity. And that everyone has those things that get them going and shuts them down. And so the more that we can, scoop onto the one pile of let's get you going, and the more we can avoid doing things that shut people down, the better we are. And I feel like so much of that trust is about communication, and having like this safe space for people to say, well, this does work for me. And you know what? That does not work for me. I think that is so critical to this piece and the way that we work together, and just remembering and checking in with our own humanity and remembering others as well. So we have about 3 minutes left. I am not very good at working my way through these questions, so please forgive me. But I'm wondering if anyone wants to share if they have any ideas of how your subrecipient CQM committee could be more intersectional, in terms of the way that we bring quality to life for people, and kind of bring in different aspects of our programs. Does anyone have any suggestions or ideas on how we could be more intersectional? Kim, I love your purple hair. I can't help but to stare at it in that picture.
I wish it was real. It's a filter, but I would love to do that.
I've always wanted blue hair personally. I don't know if there's any thoughts that you have on being intersectional. So does anyone have any thoughts on that? Okay, we can move to our next question. That's a tricky question, I know, and it's an area that a lot of us have been stuck in for a long time, so we'll come back to that in future sessions, I think. Similar to the last session, though, maybe we can wrap up this piece just by seeing, does anyone have any advice if someone's brand new in their role, they have to lead the quality committee, what advice would you give to them?
Well, Sandra, you can go.
No, I was only going to ask, it's going to go back to the intersectional part, like if we can get, like what are you really talking about as being intersectional? Because I think we may be, but I'm not so sure.
Yeah, in terms of thinking about how the HIV program is intersectional with other programs. So in the earlier session, we had talked a little bit about Title X. You know, we think about the way that HIV treatment interacts with HIV prevention, DIS, how we interact with, you know, maybe the operations committee, you know, of our organization, stuff like that.
Oh, I have a perfect and a try to make it quick answer for that. Our QM
Okay.
team actually has, we have other departments. That's what we ended up doing. And I've seen that like the QM meetings have operations there, case management. Like we initially used to have it siloed, like with just a QM lead or the QM committee. But now when we have everyone on board, then they're all aware of what we're doing. So the new format is to actually have all staff in the meeting, operations, case management, like everyone. So that has definitely been working for us. So it's everybody in there, so that they figure out which parts of the piece work with them, even though the QM plan does not necessarily say they are responsible. They still need to know what we're doing. Yeah, so we definitely do that at AHF.
I love that. I love that, Sandra. At Whitman Walker, we had done something similar where the operations committee met weekly, and every other session, I had half of the meeting, you know, and that basically became the quality committee. So every other week for half an hour, we had an opportunity to discuss. So there's many different ways that you can do it. The cake doesn't need to be cut into, what's it called, diameters. All right, so we have everyone back, and I'm seeing that the time is now 10:52. So instead of doing a report out, we're going to just try to compile notes and then put the notes in with the toolkit. That way, everyone has the opportunity to see what everyone else said, and I'm not being a meanie and taking up your time. Okay, so we'll take care of this in the notes. So this is a really important thing that I just wanted to take a couple moments to emphasize, is that you'll see in the toolkit, there is a form that's basically a grid that is having you to do some action planning. And the idea here is that some of these questions will be more relevant to you and some will be less relevant to you. And so we invite you to just ignore the questions that are less relevant to you and to think critically about what changes you can make to your CQM plan based on the journey these questions take you on. The form itself can be easily printed and used in a face-to-face committee meeting. If you're doing face-to-face meetings, which you probably are not, it can easily be shared on the screen as well, since it is a PDF. And I'm happy to even make a fillable PDF if that's something that would be you know, of interest to folks. But the important thing here is just thinking about what changes you could make and what changes you might make to your CQM plan. We understand that in a short period of time, it is impractical for you to review your whole plan, to mark up that plan, and to make changes and have that approved and all that, because the point of this presentation has been in part to talk about stakeholder involvement. And so you're not involving your stakeholders if you're making all of your changes and your updates in an island. So in using this form, we do invite you to use it with your committee, with the understanding that the changes that are recommended might not happen right away, and that's okay. The takeaway is what changes you would make, and there'll be a place on the final poster for this series that includes a space for that, for you to share what some of your thinking has been and what changes you might make. So I just wanted to take a moment to see if anyone has any questions or concerns based on the questions you see here. Again, the form was already included in the toolkit as well. Great. So I just want to see, does anyone have any questions or concerns on this? Bye, Karen. Thank you. All right.
No questions.
All right, Oscar, take it away.
All right. Well, any questions, any observation, and any comments? We have 5 minutes left to be punctual and sharp with the time, and we want to be respectful of your time, of course. And please, any comment is welcome.
I'll comment.
Natasha?
We participate, we have various staff and CAB members who participate at the county level, but it never occurred to me to actually present findings from our CQM program to those individuals to present to the county. So that is something that I might want to do moving forward. And this was helpful. I just feel like this is going to help me revamp the plan for next year. Even though we have a lot of the elements in place, it just forced me to actually see, like, are we actually doing these things? So I got a lot out of this.
Yay.
Okay. Thanks so much, Natasha. Norma mentioned that. Barely can hear the details, but it's Norma, do you have anything to, any comment or something? Comment from Dale? It's always welcome. We have like a minute. The floor is open.
Well, this is Dale. I'm excited to start talking soon about performance measures, and because that's something I do get excited about, and comes along with a lot of challenges sometimes about the systems and how our system matches up with ARIES, etc. Probably true for every agency. So really, it can be very difficult for us to start and expensive for us to start tracking new information. So just that, I'm really interested in talking about performance measures when we get around to that.
So thanks so much for mentioning that. In 2 weeks, we have a training specifically for that, care markers, performance measure. We're going to talk and dive very deep into it. And we really are totally happy to have you over and hear your expertise and your comments and your feedback in that. Thanks so much.
Thank you.
So, any other comment, any other question?
This is Brian with DCHHS. I'm really impressed with this format. It's totally new. I've never participated in something like this, so I think that this is an interesting way to do this, and it's good to see the participation from all of the subrecipients. So I'm impressed.
Thank you, Brian. From Yuli, this has been a great training. I've enjoyed being part of it, and it's great to see you all. And remember, if you learn something new, that's great, put it in practice. If you get something that you already knew, don't forget it. That's a good reminder. Angie?
Mm-hmm. Thanks, Oscar. So this concludes our second training of the series. We have 6 training sessions left, and we're looking forward to seeing you all at each of those. As was mentioned, the next session, or the next 2 sessions actually, the first one being in 2 weeks, is dealing with performance measurement. So make sure everyone is there, and you may want to reach out to your data person or team if you're not also wearing that hat, to make sure they're attending those next 2 sessions so that we can get all our bang for our buck and get our performance measurement on track at the county and with you guys' help. So Oscar, I think we're going to go to the poll now.
All right, thanks so much, Angie. Here we are for those who still remaining there. We have a minute to respond to this one. This meeting and discussion met my expectation. Please feel free to drop the polling, and the duration of this meeting was exactly too short, just right, too long. You give us your feedback. It's very, very, very important. And there were opportunities for you to share your and participate in this training session. And the 4th question is, the content provided in the meeting was too little, just right, too much, our opinion. And this, while you're answering this, conclude. Thanks so much to Hired Health, Michael and Jamie, that they are technically driving this boat and guide us into the best practices into the CQM program. And we're gonna make the continuation of this process for the benefit of our client that we care so much about.
Fabulous. Great. So that concludes today's results, today's webinar. Let me just share the results. It's good to know that we're getting our Goldilocks on and doing just right here, but please be honest in the future as well. Like, we're going to be asking questions about the cadence of this, you know, every other week. There'll be a question about whether that is manageable as well. So your feedback will help us to drive our next steps, and we just appreciate you so much. Thanks so much for joining us, and we'll see you next time.
Thanks,
Thank you.
everybody.
Thank you.
Have a good week.
Bye. Have a good day.